So let's move on now to the two treatments that have been developed to target some of these mutations that we have found. And the group of drugs that have been intensively studied over the last 10 years or so are the FLT3 inhibitors. And one now is approved for treatment of adults with FLT3 mutated AML, and that's midostaurin. Eunice, do you want to bring us through the data for that?
Sure. So we were one of the sites actually for the RATIFY trial, which was conducted over 10 years ago, initiated. This trial was looking at a drug midostaurin. Now, this drug is, I have to say, not the newest agent on the block. At the time, it was an agent that was developed as a pan-tyrosine kinase inhibitor. So it inhibited multiple other tyrosine kinases, but also hit FLT3. And the hypothesis is that we knew from earlier studies done in AML populations that the 1/3 or a quarter of patients with AML, newly diagnosed, particularly younger patients, when you looked at their molecular profiling, which we talked about, and we looked for the presence of the FLT3 mutation, that those patients had almost up to a third of them had either a FLT3 tyrosine kinase or a FLT3 ITD mutation. And at least for the ITD mutation, which is slightly more common, the prognosis for those patients was worse. Now, there is conflicting data, but the older data suggested that those patients that had FLT3 ITD mutant AML tended to present with higher white counts, hyperleukocytosis, more aggressive proliferative disease, and they were able to achieve similar rates of complete remission as patients who were FLT3 wild type. However, they had a very short event-free survival, and they tended to have high rates of recurrence and a shorter overall outcome. So their prognosis was significantly worse. So the midostaurin was developed or thought of as, even though it was a pan-tyrosine kinase inhibitor, as potentially an agent that could target FLT3 and both TKD and ITD mutated cells in vitro. And so could you add it to standard 7 and 3 for these younger patients because they had the same CR rates, but could you get better effects by adding a targeted FLT3 agent to standard chemotherapy? And earlier studies that were done in the phase 1-2 setting up in Boston had demonstrated that maybe you can even get higher CR rates. So this study was actually done through the cooperative group. It was a very, very large study where they screened over 3,000 patients for the presence of the FLT3 mutation, and they were able to identify 700 patients. And those patients were randomized to receive either midostaurin plus standard 7 and 3 or placebo 7 and 3, and then they were followed for overall outcomes. Now, this study utilized the midostaurin starting on for a 2-week period during induction chemotherapy. Then patients receive additional shorter periods of treatment with the FLT3 inhibitor during consolidation with high-dose cytarabine. If they then were able to go on to transplant, they were allowed to go to transplant, so up to 2/3 of patients eventually received an allogeneic transplant, either in first remission or in subsequent salvage setting. And if you were not able to go on to further chemotherapy or further transplant, you could get, after consolidation, maintenance, okay? So there was a lot of FLT3 used there, but the primary endpoints were really to look at the overall outcome, efficacy, event-free survival, et cetera. So when this study was presented at ASH just a couple years ago, the data was actually very startling because for years, and Jorge can tell you better than I can, for years we've added things to 7 and 3. We've added this drug to 7 and 3, that drug to 7 and 3, and when we get to the randomized trial and we look at the experimental versus the control arm, it ends up being a wash. So how many ASHs have you gone to where we've come with great excitement about a phase 2 study, and we get to the phase 3 and it's negative, right? So I think that this study actually took many, many years to read out, mostly because a lot of the patients went to transplant, so the endpoints were low, where it took a long time to accumulate. But this was the first agent to actually, when it added to chemotherapy, really show a benefit, and that was a benefit seen at a 4-year overall survival benefit. Survival curves were distinct. They remained distinct. In fact, when you look carefully at the curves, the difference in the overall survival curve seems to separate out shortly after induction and continue along the therapy during induction consolidation. Now, in interpreting the data, there is no difference in CR. but there is a difference right after that time point. So there was no minimal residual disease testing that was done. There also was, when patients went off to transplant and the other patients stayed on, the ability for those patients who didn't go on to transplant from first admission to receive maintenance therapy for up to 12 months with midostaurin. But there was no ability in the original study design to look at the significance of the 12-month maintenance. So this drug, really, midostaurin, was actually the first drug to be approved for the treatment of newly diagnosed FLT3 mutant AML patients in conjunction with standard chemotherapy for induction and consolidation only. So what are your experiences with the midostaurin? You don't use midostaurin. Do you use midostaurin?
We haven't. See, what happened with midostaurin is we almost forgot about it because this study took so long.
And there was some toxicity with it.
Yeah, and back in the beginning when we were doing it single agent, we participated on those, and there's a little bit of GI toxicity, but in general, when you add it to the chemotherapy, it really doesn't add much to the.
I mean, they're already getting intensive chemo, right?
Exactly. So that from the safety point of view, I think that, well, my perception, and of course what was confirmed with the RATIFY, is that it really is it's a pretty safe combination to give, that you get what you get with the chemotherapy, but that's about it. So, but I think it is an important addition, because we've always felt like by adding something, a FLT3 inhibitor to chemotherapy, you would get a benefit. And we've done some single-arm studies and then look at historical controls and the complications of those comparisons and how you analyze the data and whatever. But so that was always our belief or our hope, and the RATIFY ratifies that it.
Yeah, I mean, I think
really
it's the first trial to show a positive benefit for this type of targeted agent, a tyrosine kinase. I think ever since BCR-ABL inhibitors got developed for CML, there's always been this belief: could we develop a targeted kinase inhibitor for?
And actually, it's fair to say and interesting to say that part of the reason why it takes so long is because the events were not happening as fast as,
which is a good thing, and this
which
is a
was a
high-risk
good
population.
thing. So it took very long, but it was a good thing, because now we were having this population of high-risk patients, and all of a sudden we're not having the rate of events that we thought we would be having.
Right.
So.